This conference will now be recorded.
Okay, good evening. It's Monday, September 19th, 2022, and this is the AnCan Advanced and Prostate Cancer Group, and I'm Herb Geller, who's sitting in the hot seat tonight as your moderator, and I welcome you all. And with that, we have two new people, and so the way we work is I will start with Norm Pollock, who's new to us. And Norm, what we do is we ask a bunch of questions to help introduce you to the group. And then at the end, obviously, we'll have a better picture of where you are. And then, of course, I will ask you if you have questions for us.
Sure.
So if you have questions for us, you will have time. We will be here for you. Okay, so Norm, how old are you?
70. I'll be 71 in October.
Okay, and where do you live?
Crossville, Tennessee.
Crossville, Tennessee. And when were you first diagnosed?
Mid 21.
Okay. And at that time of your diagnosis, do you remember your Gleason score?
I was a 7. Well, I was two 7s. I was a 3-4 and a 4-3 7.
Okay.
I was an X-ray tech, so I got a little bit of medical background. My wife was respiratory, so
Okay, so you know your way around. And what was your PSA level when you were diagnosed?
7.9.
7.9. And where was that done?
UT, University of Tennessee, Knoxville.
University of Tennessee. And then do you know you have a primary physician who's taking care of you at the moment?
No, my primary doesn't want to get involved. I pretty much just with my urologist.
Well, right now you just have a urologist.
Pretty much, yeah.
As running your cancer care. Okay.
Right.
And then
Okay.
so
Well, I was going to say I came down with epididymitis, and he's going, "Why didn't you go to your urologist?" Well, he's like an hour away, and he's busy. You can do this.
Right.
Yeah, it's like
So what treatment did you get so far?
Radical prostatectomy.
Okay. And anything else?
Nothing else so far.
Uh-huh. And what was the result of that RP? What was your PSA after your RP?
It was a 9, a 5 + 4.
No, I mean, so excuse me. So you had a second Gleason score from the pathology tissue?
After the prostatectomy, it jumped to a 9.
Okay, so the prostatectomy went from 7 to 9.
Right.
Okay, so given that you had a 9, did they do any scans for look at extraprostatic potential sites?
Not yet. He wanted to see how the PSAs went.
And how was your PSA?
3 months was 0.03, 6 months 0.07, 9 months 0.1.
Okay, so it is going up.
Yep.
But are you under any other treatment other than your RP?
This Friday I have an appointment with a radiation oncologist.
Okay. But right now you're not taking any drugs, you're not getting any treatment
not
at
yet.
all.
No.
Okay.
He wanted to do one more PSA.
Right, and
Go ahead.
So when they did your biopsies and with the pathology tissue, did they do any genetic testing?
No, not yet.
Okay. So here you are, you're like a year, you're saying it's sort of a little over a year.
Yeah, November 29th was my prostatectomy, so I'm just.
But it's sort of a year past diagnosis. You had an RP,
right.
And your PSA is going up.
Right.
So tell me what you think, what questions might you have for us?
Basically, I was wondering questions to ask of the radiation oncologist here. And I don't know. I don't know. One of my questions to him is going to be who's going to handle the oncology end of this, him or the radiation oncologist or the surgeon or an oncologist. So what do most of
Right.
you guys have, I guess?
So, I mean, I think I mean, it's clear you have extraprostatic disease,
Right.
right?
Sure.
And then the radiation, and then to me, I would want to know where that disease is.
Right. Well, I
So,
mean, according to them, they thought, and from what I've read, I guess they're kind of right that to jump into it so early, there's not enough PSA expression to really find much anything at 0.1, is there?
well, I thought you said that it's 1 now.
No, at 0.1.
0.1. Okay.
Point,
So
yeah,
0.1 is what it is right now.
correct.
Yeah. So basically, they're not going to be able to see anything on any scans.
Right, right. So we're early in the game, but with it jumping that fast, it's there. It's my guess, and it's his guess too that it's there. We're just waiting for it to bloom
Right. I mean,
enough to find
I
it.
mean,
Yeah.
I mean, chances are when you have a 5+4, there's something outside the prostate.
Yeah, I was, yeah, it was, boy, I'm drawing a blank on the word. Um, Extracapsular.
That's right. But
Yeah,
is that what the pathology uh,
yeah, yeah.
said?
The
So I'm
path
going to
report.
ask
No,
Rick to sort of fill in, and I think I know what Rick is going to say about what potentially he would do. So I'm going to call on him. Are you hearing me?
I am now. I was hearing you, but I have my mic turned off. Um, yeah. Hi, Norm.
you know,
There's a couple of things I think that are important. I don't think that to this point anything has been mishandled or I mean, the only thing I think they should have done, if it were me, I would have gotten some regular bone scans and CT scans. How many cores originally were positive back in the day
well,
when you had your biopsy? Did you have a lot of
there
cancer
was
or just a couple of
no,
cores?
there was five. It was almost a false negative. There was 5% of one core, and that was
Okay,
they read it. UT read it as a 3-4, and Hopkins read it as a 4-3. So,
okay.
and the one guy I
So,
talked to at Mayo went, I don't know who's right.
right. So when you don't have that much cancer, I can understand why they probably would not have done any scans. But for good
Mhm.
order's sake, even though you're a little early for a PSMA scan, it'd probably be smart to do a bone scan and a CT scan just to cover yourself. And I think the urologist should have thought about doing that once you were upgraded to a 5+4. That said, um, well, I should ask you, in that 5+4, was there anything unusual when they came back? Did they talk about any unusual patterns like cribriform or
No,
introductal or anything strange? Good.
no, there
Okay.
wasn't. It was, yeah.
So I think there are two things that need to be done. I mean, it sure looks like you're creeping up, but you have fairly indolent disease, which is a good thing. I think you need to get you need a urinary medical oncologist on board as a kind of a quarterback. Um, and then working
Excuse me,
with the quarterback,
did you say a Euro medical oncologist?
So
we'll put it in the chat window. Somebody,
nice.
first of all,
Okay.
let me tell you where the chat window is.
Yeah, I don't see it.
Right. There's a little bubble in the top right of your screen, like a speech bubble. And if you click on that, it'll open up the chat window. You see that?
Yes.
Right at the top right. There's a comment
Okay.
from Carl and a response from me in there.
Right.
And
I see
Herb
that.
has written in genitourinary medical oncologist.
Right.
Now, that is a medical oncologist who specializes in prostate cancer. And the
Okay.
reason that we frequently recommend that is because general medical oncologists oftentimes don't keep up with what's going on in prostate cancer. And what's going on in prostate cancer changes very, very rapidly.
Right.
And a lot of these local general medical oncologists know all about breast cancer. They don't know enough about prostate cancer. Sadly, and you guys are going to get sick on this call of me saying this, but we've just figured out that possibly next year there will be more prostate cancer diagnoses and deaths than breast cancer. So we got a real issue here in our community. So you need that GU Med-Onc. We'll come back to where you find them. The second thing I would do is I'd keep a real tight eye on your PSA. Once you get up to a level closer to 0.5, they'd be able to do a PSMA scan and most likely get a result. Between 0.2 and 0.5, some people get results, others do not. There are men on here who have gotten results and there are others who have not. Under 0.2, it's pretty rare to be able to get a result. So you've got to hang in, and essentially, as long as there's nothing going on right now, and you monitor this closely every 6 weeks, or, as it gets closer, maybe every 6 weeks, every 3 months.
We're doing every
you
3
just have
months right now.
Right, you're on every 3 months, but as it gets a little higher, you may want to go to every 6 weeks. And once you get to that 6-week mark, that 0.5 mark, you shout out for a PSMA test. Now, if you've got a good medical oncologist on board, they're going to know that. I don't know how good your radiation oncologist is. I assume it's probably somebody local.
Yeah, he's at UT also. The surgeon's great. I mean, I can discuss tests with him, and he rattles off all the studies, and yeah, and he said the same thing. There's not much we can do until we hit 0.2, then we start thinking about stuff, and so we've had
Yeah.
that discussion too.
And 0.2, to be honest, 0.2 is a little low. I mean, they used 0.2 as a threshold for PSMA, but for in a different, not in a recurrent situation. They used it for initial diagnosis, but it's debatable. But I think one of the things that if you have a good relationship with your urologist, you should be talking to him about getting a genitourinary medical oncologist on board now.
Okay. Yeah, he's good about that kind of stuff. He's not, yeah.
Now, the big problem is where and who, because I don't know that UT Knoxville is going to have anybody, and I can tell you that we're not super impressed with Vanderbilt. So if he sends you to Vanderbilt, check with us first who he's sending you
Okay.
to.
I don't want to
The
go to
problem-
Vanderbilt anyhow.
Well, the problem at Vanderbilt is they've got a couple of young GU Med-Oncs, and they just don't have the seasoning yet. And so
Okay.
we've got to, we know them, we've got to be sensitive. So I've given you a long answer, but number one, keep watching. Number two, get a GU Med-Onc.
Yeah. Anybody in Atlanta? I can get to Atlanta about as easy as I can get to Vanderbilt.
Tough. That's again a tough. I mean, yeah, there are people at Emory, but we don't love them. I would say, even though I know it's a bit far, I would say Houston is a very good option.
Okay.
Chicago is a very good option.
What
And
about the
most of
clinic?
these,
I
most
came from
of these
Ohio.
people,
I worked for the clinic, actually.
right. So or you can go, yeah, you could go to the James. We've got people at the James, but most of these people will work with somebody locally. So, you know, after you've seen them one time, they're your quarterback, but they'll work with local people.
Okay. What about Mayo in Florida?
I wouldn't go there.
Okay.
If if you're willing to go to Florida, I'd send you to Houston.
Okay.
So, I mean,
Who's
chances are,
in Houston? I'm drawing. I forget what's Sloan Kettering in Houston. Who's?
No, it's MD Anderson, but I don't think that's
Yeah,
where we'd
I
send
couldn't come
you.
up. Yeah, I couldn't come up with the hospital.
Yeah, so it's MD Anderson, and we have options at MD Anderson, but we also have an ex-MD Anderson person who's at Houston Methodist, somebody who was at MD Anderson for 14 years, and the consensus from most people who see her is exceptionally positive. That's not to say, you know, we couldn't send you to a couple of really good people at MD Anderson as well,
Okay.
that we have no problem in recommending if you prefer MD Anderson.
Yeah. Do they do telemedicine and not have to go there, or do I need to go down there?
I don't know. Is Mikey Yancey on today? Did I see
he
Mike?
was, yes. Mike is
I'm
here.
here, and basically they're not going to do a telemedicine until you see them first time in person. Then telemedicine becomes an option.
Yeah. It's hard for me to get there. My wife's got Parkinson's, and she's going for her deep brain stimulus here in the next month or two. So.
You can always ask. They might make an exception. Plus, we find that each place has a different policy about that.
Yeah, a
So
lot of
it's
them are getting better at.
yeah, always worth asking.
Yeah, worst they can do is say no.
Yeah.
Right.
And then this is John. A couple of things I can think of for you to ask your radiation oncologist Friday. One is, are they going to start you on some hormone treatment first?
That's what I was wondering. Yeah.
And I suspect they will. And they have some choices about what hormone treatment to start you off on. So you can get familiar with the two different kinds of LHRH drugs, one which is a blocker and one is an agonist, and one of which can cause a little flare-ups. So you prepare with another drug first, the other one doesn't. So there's some various things there that you can talk over with the radiation oncologist, how to start up. And the second thing I was thinking you could talk to them about is where exactly to radiate. You know, you don't have a prostate, but you still have a prostate bed and you had some extracapsular extension. So of course they're going to want to do that. But then the question is he going to go on to radiate the entire pelvis? Because if you do have some prostate cancer away from the actual site of the prostate, it's probably in one of those lymph nodes in the pelvis somewhere. So there's might be two ways to think of the target of the radiation, as the prostate bed or the whole pelvis.
Okay. I was just reading about apalutamide along with the luteinizing hormone, or what with ADT, whether it's an agonist or luteinizing hormone. And do you know anything about the apalutamide?
Well, apalutamide, well, maybe I'll ask Len to fill it. Len, I don't have to hog it. Len, you can talk.
Sorry, I was muted. Yes, apalutamide is an androgen receptor blocker. There are a number of them. Xtandi or enzalutamide is another. Darolutamide, Nubeqa, is another. They are all about of equal effectiveness, but they have different side effect profiles. enzalutamide and apalutamide are like kissing cousins. The structures are nearly identical, and so are the side effects. Both of them introduce considerable fatigue and brain fog in most guys, not everyone. Whereas darolutamide does not cross the blood-brain barrier to a significant degree, and therefore there is less fatigue and less brain fog. But all the other side effects are similar. You do lose muscle mass, you do have some degree of fatigue, you will have some bone loss. So you want to, if you're on any of these drugs, you want to maintain a pretty rigorous exercise program, aerobic and weightlifting.
I've been doing that for the last 6 months. Plus, I cut and split about 10 cords of wood a year because you still heat with wood. So
Good.
done that most of my life. So I think my bones and muscles are in fair shape, but we'll see.
Right, well, if they do give you an androgen blocking drug or either an agonist, you probably would like to have a bone density measurement before you start.
Yeah.
Because even those of us who were experienced runners and done lots of activity find out that at our age, somehow we're osteopenic.
Yep.
So before you start, it would be important to get that measurement.
Excuse me, Herb.
Some of us find out we're osteoporotic, Herb.
Yeah.
Well, that's even worse.
I know. You don't have to tell me.
I said even osteoporotic. I didn't exclude osteoporosis.
Okay.
But
Excuse me, Herb.
Yes.
Then I believe he should get a baseline testosterone test done. It would be, I think, a good idea.
I assume they'll always do that.
No, they
I
don't.
Maybe I'm
certainly-
wrong.
No, don't make that assumption. A lot don't. So Jim Marshall has a good point to be sure that before you go forward on any treatment, even right now, get yourself a baseline testosterone so you know where your testosterone is right now, Norm. It's a great point.
Although Herb, if he happens to start this now, then he will not be able to get essentially a PSMA test.
Yeah, but we're
Well-
not saying he's going to start it now.
Okay,
We're
I want to
saying-
make sure he understands that.
Right, but he's
Right.
not going to start hormone therapy right now. But before you start hormone therapy, you should have done, as Jim correctly says,
Right.
a PSMA test,
Right.
and you should have gotten a baseline PSA.
Right. Well, baseline testosterone. Norm, we lost your screen. Are you with us?
Uh-oh.
You're there, but we can't see you. Can you hear us? I
He'll be
think
Must have
back.
lost his internet signal.
right. So I think we're going to. I think we can come back if Norm comes back. Oh, so yeah, Don mentioned he had to come back as well. So let's give him maybe another 30 seconds. I think he just disappeared. Oh no, he's there. Caller 01.
Hi, this is Norman Pollock.
Hi, Norm, you called in.
Yeah. Yeah, we live in a third world country here. The internet's terrible. I'm going to see if I
Okay.
can't get back on here. So
Well, no, you're here with us. I mean, I think
Right.
the discussion was that before you even think about an LHRH drug, you want to get a baseline serum testosterone as well.
okay, yeah. But last I heard was bone density, and then I was gone.
Right. And then the other measurements that Jim Marshall brought up was that it really would be good to have a baseline testosterone so we know that any of these drugs are working in
Sure.
lowering your testosterone.
Okay.
And then, I mean, so when did you send when you had your surgery and it was upgraded to 5+4, did you send any of those pathology slides to Hopkins again?
No, I didn't.
Once again, you sent it to Hopkins the first time, which was a very smart thing to do.
Will now be recorded. Oh. Yeah, I'm muted. That's not working.
Okay. No, I don't know. We lost him again.
I should be back. I'm back on the internet.
Oh, yeah, right. You're back on the internet, so you could turn if you. At any rate, given that you sent it to Dr. Epstein to begin with, it might not be a bad idea to let him look at the slides from the prostatectomy.
Okay. Can I ask why? Just out of curiosity.
You're muted, Rick.
One very good reason is that if you're not a 5+4, and if there's no complication right now, it's going to impact the amount of time you spend on hormone therapy, depending on what your real, your verified Gleason score is. So if they came back and said, no, we still think he's a 4+3 and not a 5+4, then it could change the amount of time you spend on hormone therapy in your favor. So I think we should probably move
we should
along.
move on. Yes, no, I agree.
Okay. Thanks, guys.
Okay, so our second new person is Peter Sanders. Peter, are you still with us? Do we have?
Yes, he's there, but he needs to, Peter, you need to switch your,
Peter,
you need to
turn
switch
on
your, you need to turn your microphone on, Peter.
Yeah,
There you
now
go.
you're not muted.
Okay, there we go.
Good. Okay, so Peter, you've heard our spiel with Norm, and I'm going to essentially ask you the same questions so we can get a sense of where you are. So how old are you?
70.
Okay, and where do you live?
Glorieta, New Mexico, outside Santa Fe.
Okay, and when were you first diagnosed?
March, I believe, of 2020.
Okay, and did you know your Gleason score at diagnosis?
You know, I think it was 9 out of 12.
No, that's the number of cores. Did they give you a
No.
number like 3+4, 4+3, 5+4?
It was high. I can't.
High, okay.
It
And
was high.
And what about your PSA?
186.
186 at diagnosis. Okay.
Mhm.
And so where was that diagnosed?
At Christus St. Vincent Urology.
Okay. And then with that, what did they do? What did you have any treatment?
Yeah, they sent me to my urologist 2.5 years ago, and he told me that the only option I had was to take Xtandi and Lupron.
Okay. So that's what you got is Xtandi and Lupron.
Yeah, I've been on it for 2.5 years.
Okay. And then what did it do to your PSA?
It's dropped to negligible.
Okay. And that's been,
0.0145 or something.
okay, so it's negligible. And at the same time, did you have any genetic testing of your tumor, or did you have any genetic testing of yourself?
No,
Okay. And right now, your prostate, you've been on Xtandi and Lupron for essentially 2.5 years,
yes.
and it's working.
So far, so good. You
Okay.
know,
And I mean, there are all these other questions that we would ask is in terms of had you had appropriate scans, had you had any scans to try to localize where the cancer was?
yeah, it's in my pelvic. So it's stage 4 and it's in my pelvic lymph nodes. And my oncologist told me, I thought he was mispronouncing it, but he said, I have shoddy spots on my bones in the pelvis. And he said he could almost guarantee me that I had it in my bones also. But they haven't, maybe 6 months ago, they had a bone density done on me. And I've got some in my pelvic bones. And I see the oncologist. Then he sent me to make sure with the dentist that I'm okay to start me on treatment, which I assume is going to start this Friday um, for the period. I'm sorry.
Right.
When
So
we talk about,
basically, right. So basically, if they discover, as we called it, osteopenia or osteoporosis while you're on this treatment, which is not an unusual thing to discover, they will give you a drug which will increase your bone density. But at the same time, when you're taking that drug, it makes dental work more complicated and sometimes contraindicated. So that's why you got to go to the dentist while you go to see if you need any dental work before you start getting these bone density agents. So
and
who is
that's
your
been done.
current on, who are you being treated by a genitourinary oncologist?
Don't know the answer. I'm seeing Scott Herbert, who's considered, I don't know what his qualifications are. Um, he was my wife's oncologist for breast cancer uh, quite a few years ago.
Okay, so that already answers our question. And then you've heard us tell before, we just said it a few minutes ago, that prostate cancer is not the same as breast cancer, is not the same as other cancers. It's more tricky, and there's a lot of movement in the area that most general oncologists just can't keep up with. So our major advice, it would be to see a GU oncologist,
Okay.
somebody whose specialization is genitourinary oncology.
Okay.
So I guess after those questions, do you have any questions for us? And then I'll open
No,
the
you know
floor.
this. This got started. Somebody that knows somebody said that they recommended doing this because they thought that there was benefit in going off of the Xtandi for a period and either not taking it or taking a substitute for it and then coming back on, and it may be more effective. And I'm not real fond of the Xtandi. It sounded good to me. I mean, I'm pretty naive, but I'm kind of tired of the headaches.
Right. Extend. I mean, you heard that enzalutamide is one of those drugs which can cause kinds of behavioral changes. So, but I think here's a case where you're seeing an oncologist and he's giving you what he thought was the standard treatment. Yet there may be others which could have been less harmful, less aggravating. And that's why I think a GU oncologist would be the person you need to see.
Okay.
So, I mean, they will talk to you about whether it's time to go off. You know, you've been on for 2.5 years. Maybe, given your PSA what it is, maybe they will give you a drug holiday. But I think it shouldn't be done without consultation with somebody who's a specialist. Rick, you look like you're ready to jump in.
Peter and I spoke, I think, last week sometime, and I didn't realize at the time that this was his primary treatment. So you've never had radiation and you've never had never had surgery, is that right, Peter?
That's correct. He said it was beyond that.
Okay, well, that's not the thinking today. And whilst he may have treated you in a, I don't even want to say acceptable, because I'm not sure I would accept that, but the way he treated you, today it's common practice to treat the primary. So you're still eligible to have to have either surgery or radiation. Most of us here would opt for radiation. And there are several people on this call right now, including Herb, who were diagnosed metastatic and who subsequently, after chemotherapy or second-line anti-androgens, had their prostate treated. And one of the things I think I would do is talk about getting radiation to the prostate. And then after that, maybe thinking about a drug holiday. And as I mentioned to you, if it were me, I'd probably go visit Alan Bryce at Mayo in Phoenix. And if you can't get an appointment with Dr. Bryce, there are a couple of other good doctors there too, who specialize in prostate cancer. And I think they would, and I don't think, I know that they too would be looking at treating your primary, because we've seen them do that with other men who aren't on the call today, but who have gone to Mayo Phoenix. So, and a lot of this, if you're a general practitioner, you just don't keep up. He probably keeps up with breast cancer because he probably treats more breast cancer people, and he probably leaves the prostate cancer people to the urologists locally, and he's behind in how the disease is treated now, Dr. Herbert.
Understood. Okay.
So does anybody else want to weigh in here with suggestions for Peter based on his situation? David.
Yeah, you've got a really good chance of getting ahead of this disease. And Peter and I know being in Santa Fe, you're kind of remote, but it's really worth. I just want to confirm that it's worth your time to follow up and find a real good GU med-onc, because you've got a really good chance of having a long life in front of you, but you got to get on it. Is my point. And I would jump on it if I were you. If you're not that far into it, and you've got a good chance of, like I say, I saw it 3 times, living a long life yet.
Okay. Yeah, it was. Okay.
And I think you know my sister Ava, right?
Say again?
You know my sister Ava, who lives in Santa Fe. Maybe that's
Yeah, that is my connection. Yes.
Got it.
Uh-huh.
That's my sister. Okay, good.
So my wife Ava and your sister Ava are very good ski buddies, etc.
I know you're got it. Okay, great. Good to meet you, Peter. Happy you're here.
Right.
Thank you.
And I
Peter,
think,
this is John. Just a small point. As you went through your history of what they probably meant by that word shoddy, they didn't mean sloppy or messy or anything like that. Shoddy means looking like shot, looking like
Looks like a
buckshot.
shotgun. Yeah, I have a twin sister that's a nurse, and she explained that it looks like somebody shot it with a shotgun. Yeah, that was her interpretation.
So it means little tiny BB-sized lesions.
but I
Yeah.
think that the consensus would be, Peter, get yourself to a good geo-oncologist who can be the quarterback. And they can run whatever tests and listen to your history and current situation, and then make decisions about what to do next.
Okay.
Together, you can do that.
Okay.
And then please come back and let us know how things are going.
I will.
Okay, any other questions for Peter or before we move on?
Yeah, I mean, the only other thing I was going to say, if you need any more help or assistance in trying to identify the best oncologist, come back to the group, we'll point you, or reach out to David. But I think from where you are in Santa Fe, probably it's a short flight to Phoenix, and the genitourinary staff, both the radiation oncologists and the medical oncologists and the surgeons, are all very good at Phoenix. So
Okay.
it's in Phoenix. So I think that's probably where I'd start. If you don't like the idea of Phoenix, come back to us. We'll give you names in other
No, Phoenix.
locations.
No, Phoenix works. I have a brother in Tucson area. Be a good excuse.
Okay. Whereabouts in the Tucson area?
Green Valley.
Well, I'm 20 miles south of Green Valley. I'm in Tubac, Peter.
Okay.
Peter,
Okay.
Dennis, I'm also in Arizona, and I use Dr. Parminder Singh at Mayo for 6 years, and he's treated me very well.
Okay, so it looks like the consensus is that Mayo Phoenix is the place to look.
Good.
Okay, and please come back if you have any further questions, or keep us informed of how things are going.
Okay.
Okay.
Thank
So
you.
we will move on to. Yep. Go ahead, Norm.
Who at MD Anderson should I try to see?
I would suggest Paul Korn, Corn. It's probably or Anna Aparicio, but I think we really like Paul Korn. And at Houston Methodist, I'd suggest, which is right next door, I'd suggest Eleni Efstathiou, Efstathiou. We'll put that one in the chat window because it's a little tougher than Korn. Now, I don't know, Ken, what's the story with telemed with MD Anderson? Do you know?
Yeah, if you're not located in Houston, they don't do Zoom chats, but they will just talk to you on the phone. You know, they won't sign you up for a Zoom chat because they're not authorized to do a Zoom chat if you're not in Houston or in Texas. But I don't know which other states they have agreements with. So I just talk to Paul on the phone, you know. Can you hear me?
Ken's all over the place, but he spends a lot of time in Phoenix, but I wouldn't say he's in Phoenix anymore.
No, I'm in Phoenix now.
Oh.
Just for a few days, then I'm off to Wyoming.
Oh,
So
you don't stay put at all, do you?
Well, at the moment, those days, I got to use them.
Okay. So thanks, Ken. We will get back
Yeah,
to you in a few minutes.
no worries.
Okay. So let's move on. Les, tell us what's up.
Okay, a couple of weeks ago when I was preparing to go to get some surgery done on my, they were going to remove my left testicle, economy, and that was done. I had contact with Dr. Smolovitz, and he was giving me advice too, but his contention was that he saw nothing other than where I was headed, so he had no additional advice. So anyway, I had the surgery done, and I'm a bit uncomfortable, but I guess that, well, I didn't have much choice. So I just thought I'd make an update from what I had a couple of weeks ago.
So
Is
Les,
the
did they do pathology on the surgical specimen?
We didn't see any results of that. We assumed that they did, but hadn't seen anything, not yet anyway.
Because it would be interesting to confirm what it actually is.
It sure would. We've
Well,
all been waiting.
well, they did a biopsy before they did the surgery, a month or so ago, and they confirmed that it was prostate cancer.
I mean, because we did discuss the idea that it's pretty rare because of this barrier.
Yes, but they did several things. They finally confirmed that it was in fact
Okay.
prostate cancer down to the testicle.
Okay. Did it change your PSA at all?
Well, I haven't had the PSA tested since.
Okay.
This was done, just a few days ago. So.
Okay. Well, hopefully you'll have a speedy recovery.
I hope so. It's not comfortable right now.
Well, we just discussed it last week. There's all these pain meds that you can take.
Well, yeah, but a lot of them I can't take because I'm allergic to them.
Ah.
I'm on
Okay.
tramadol. They only gave me a few pills for that, and otherwise I'm just on, there's over-the-counter pain meds.
Any comments for Les? Well, I think I can summarize by saying we all wish a speedy recovery.
Thank you.
Okay. And you'll keep us informed.
Yes, I will. Thank you.
Okay. Carl, what's up?
Hi. I'm trying to cut down on things that I want to talk about tonight, so I have other people who have a chance to talk. But the very first thing I wanted to talk about is this conference that was held yesterday in Manhattan. This is, I think, their second or third. It is done jointly by Sloan Kettering, Weill Cornell, New York Presbyterian, and Columbia. It was very well organized. Susan Slovin from Sloan Kettering, Mark Stein from Columbia, David Nannis from Weill Cornell, as well as Scott Tagawa. And what I found even more interesting, after they each gave a lecture, and there was at least 7 or 8 different specialists that talk about anywhere from mental health to Pluvicto to nutrition and advanced prostate cancer, etc. So after that was over, they had round tables on a different floor with a box lunch, and you were able to sit at a table with these specialists. I had a chance to sit next to Scott Tagawa at one point, who I know. He knows me because I've participated in several of his trials. And one thing that few things I mentioned to him was about Pluvicto. And he did confirm, which I think we all knew, is that the distribution is still being made to those centers which have had prior experience
Right.
with
Right.
Novartis.
We talked about that last week, Carl.
Right.
So what's new with you? What about you?
Okay, well, the Pluvicto was kind of interesting because that's one of the things that's on my radar as a result of discussions here. I had my 10th treatment with chemo this morning, today, and that's Jevtana and carboplatin combination. As of now, I'm feeling fine, and it is expected to continue for at least another 2 treatments till we get to 12. And then at that point, we'll have scans and see where we're at. In the meantime, my case is going to be reviewed by the Rutgers Tumor Board later this week to discuss my Guardant liquid biopsy results and related items from a genetic standpoint. And there's a Dr. Ganesan, who is very well known, who is going to be presenting that case for me. I hope it will shed some light on the liquid biopsy results. And what I had expected were several things, one of which whether I can re-challenge olaparib. And I couldn't see anything on the report that said that I could. I forwarded the report to Dr. Beltran at Dana-Farber and Dr. Catherine Marshall at Johns Hopkins. I have not yet heard back from Dr. Beltran, but Dr. Catherine Marshall did get back to me, and she said something which I found was very interesting. She had said that, I want to use her exact words. She responded, it says that looks like a reversion mutation, so unlikely that your disease would respond to olaparib again.
Yeah, without knowing, Carl, what actually is on the report.
Let me cut in right here. This is exactly what happened to Professor Bill, God rest his soul. That after he had come off the olaparib and about 2 years later, it appeared that his BRCA had reverted, and he was germline BRCA like you are. And it appeared his BRCA had reverted to wild type. I have no idea how this can happen, but it does happen. So, you know, once you revert, and the same conclusion, we had the same conclusion for him. Some of you guys who have been with us a while, like Len and Dennis and the Dennises and some other guys will remember this. And so it was never an option for him to go back on a PARP inhibitor. Have you sent this report to any of our guys, Carl?
I'd be glad to do that. If you would like to get it, or Len would like to get it, I'll be glad to share that with both of you.
Why don't you send it to Len and let Len take a quick look at it and see what he thinks. Were there any other actionable mutations that were identified?
The report, which I'll bring up right now, it says, let's see, detected alterations, BRCA2, I don't know, S1982FS, never heard of that. PIK3CA amplification, but there's no FDA-approved therapies. And then there's another BRCA2, A1972_S1. I've never seen these before. And additional biomarkers, it says MSI high, not detected. Okay, so that I'm still MSS, which I knew I was previously. So in my initial review, again, I don't know how much I've really got out of it, but again, Len, hopefully you'll be able to maybe shed some light on this as I send this to you momentarily.
Okay.
There's some work being done. Maybe one of the guys will know, Ben or one of the others. there is some work being done with PIK3 because I remember reading something about it, but I can't remember exactly what. Does that ring a bell? It's not FDA approved, but there's something going on with PIK3 in terms of trials. Does that ring a bell with any of you guys?
Yeah, that, I can't come up with the drug right now, but it had shown some modest activity in guys with the PIK3 mutation, but there were substantial side effects.
Right.
I mean, I remember thinking I wouldn't take the drug for the modest benefit and the serious side effects. I didn't think it was worth it. I can't recall the drug right now.
Yeah, I'm pretty sure I bookmarked it, and I've just got to see if I can find my PIK3CA bookmark, but there was something going on. I think if you went to clinicaltrials.gov and put in prostate cancer and PIK3CA, you probably would find whatever it is. But I do remember reading something about it recently, and I think Len's right on the money. That was, I think, what my response was too. So,
I mean, actually, I just checked. There are 3 trials with prostate cancer, or 6 trials listed with prostate cancer and PI3 kinase, of which really only 2, there are 3 in this country. So there are some trials with PI3 kinase inhibitors and in prostate. But again, that was a quick glance, just at clinicaltrials.gov. So Carl, so the idea is that right now you're still going for chemo, things are hopefully responding, and we'll just see what happens.
Right, for at least 2 more infusions, yes.
Right. Okay. So we will keep informed.
How are you handling the chemo, Carla? You seem, we look at you, and compared to some of the other guys, you're amazing, man. I mean, you look like you're doing well. Are you handling it okay, or are you just fooling us?
Yeah, no, handling it quite well. What they do is that on the day of the infusion, they have these pre-meds. They give me Pepsid, they give me a nausea medication, the dexamethasone, which I'm only on 0.5 every day. They gave me 10 milligrams of dexamethasone this morning. And these do last between 2 to 3 days with very limited of any side effects. After that, the 4th, 5th, 6th days, there's some more fatigue, a rare nausea, but other than that, it's really nothing of any real significance. So that's why they're also agreeing, well, let's keep going, just like Ken Anderson, right? He keeps going and going.
Well, I mean, I do know one thing, that Dex has you flying, because they gave me 8 milligrams before they replaced my hip. And I felt no pain for 2 days. I felt so good the next morning. I drove myself home over 40 miles. The morning after that, I wouldn't have even thought about it. I want to tell you. So I think I put that down to the Dex. Feel no pain, Dex.
They did say I was going to feel like Superman. So
right. I mean, steroids are just wonderful. They make you feel great. So, but I'm not going to. But again, it's palliative. It isn't real.
And I think I also mentioned I did complete 5 rounds of radiation on my back by my left rib. So.
And how is that working?
Seems to be
pain
working.
Gone?
Pretty much, yeah.
Okay, great. Okay. Anything else, Carl, or else we'll move on?
I guess, one other thing, and I know that Kevin Dagnasco was in this conference yesterday too, I found very interesting is that Weill Cornell, David Manis just opened up a clinical trial, and it's called the Whole Food Plant-Based Diet Study. I said, wow, this is really something totally different to be a clinical trial. And there's a company called plantable, that anybody can get these plant-based foods and go on the diet. And Dr. Tagawa did say a number of the doctors went on this diet through Plantable and got very positive results. And they're saying any of us with BMIs above, and I have a big BMI right now, but it would really benefit just not only health overall, but benefit the control of the cancer. So I'm seriously considering doing something like that. I got to get rid of my carbs. And you guys have said this before. No sugar, no carbs. So it's interesting they're having a clinical trial for this.
Yes. I mean, that was known. I think they had a small trial. This may be a larger one. Okay. Interesting. We can all eat plants. All righty. We can. Pat Martin, what's up?
Get unmuted here. Last
You're
Wednesday,
good.
I went up and I had some scans up at Seattle Cancer Care. They come back, the bone scan come out real good. No problems with my bones. The CT scan of my abdomen and pelvis, not so good. You know, there's one of the things when they were talking about the lymph nodes, they just said numerous lymph nodes at the level of the diaphragm down, and then they listed 3. I was able to count at least 10 that they measured and give me numbers on. I've got one on each adrenal gland. I've got one.
You're muted again somehow. You just got muted. Now you're
Where
not.
did I leave off? Where did I leave off?
Hard to
The
say.
adrenal gland.
Anyway, so on this Friday, I'm going to go back up and get started on Keytruda and go from there.
Okay. And how are you feeling?
Doing good. Back down to the gym again. Haven't been going. I had some other health issues through July. Got over them now, and couldn't lift nearly as much, but I'm lifting. So, and I'm still back on my walks, getting back on my walks, a couple miles each day, sometimes more.
That's great.
Seldom less.
That's great.
Yeah.
We should point out for those who don't know that Pat previously established that he was MSI high.
Yes.
And that's the reason why he's starting Keytruda. And that's an important factor.
Yeah. I've known for 3 years that I was MSI high, and the docs always prep me, you know, any next thing we do is going to be Keytruda, immunotherapy. And so first time I looked into it, I thought, I don't want to go into this because all it listed was all the side effects, and it wasn't effective for very many people. And then I read a little further, it was only the people that had MSI high that it was effective on. So I resolved to use it.
Okay. Well, it's been working for people, so it should hopefully work for you.
Can I ask what's MSI high, please?
Microstability. Go ahead.
Microsatellite instability.
Do you want to just give a very short, Ben? We'll get Ben to do it. Go on, because he's smiling. Ben, tell the gents in simple language what MSI high means and why it's a good thing if you're getting Pembro.
So there's sort of a genetics signal, sort of a repeat of DNA that they can use to indicate cases where you have a certain kind of DNA repair problem. So for various cryptic reasons, this is called microsatellite instability. If you have variable number of repeats in these special segments of your DNA, it indicates that you're a candidate.
Okay. Great.
You and Peter Kafka should commiserate. You know,
Right.
he's on Keytruda also.
That's why it's so important not just to get genetic testing with the genes that came down through your parents, but get your tumor tested, because that's where this MSI high shows up.
Right, and not only get it tested, but periodically get it tested because things can change.
Right. Yep.
So, and in fact, having the tumor tested is in some ways more valuable than your own genetics, because if there's a mutation in you, it should show up in the tumor anyway. Then you can see if it's back as germline or only specific for the tumor. Okay, Pat, thank you. Joel Blanchette, tell us what's up.
Okay, I just put a long summary in the chat window, but basically my PSA has gone up from 3.6 in January, had some SBRT to my right occipital condyle bone in my neck, and that didn't help much. Cancer is still active there today, even though some of it has died. But my last PSA on 26 August was 9.4. I'm sorry, 12.9. 9.4 was 2 weeks earlier. So my PSA basically is zooming up. And so I took my fourth PSMA PET scan on 1 September, and they found 20 new spots on my bone of prostate cancer. SUV max decreased from 11.4 on my third PSMA scan to 8.7 on my neck. So that's good. That's how I know some cancer cells have been being killed, dying. And Dr. Eblin, my radiation oncologist, said they could not anymore radiate because with SBRT because I had too many spots. Dr. Antonarakis agreed with that and told me that now that my PSA has crossed over 10, which he was waiting for, that I should now go on 6-month short course of ADT and maybe some Zytiga, abiraterone. And so he told me he could no longer be my GU medical oncologist, which probably was a worse blow to me than finding out all my spots of cancer. So because I'm from Virginia, basically, he's very concerned about his license, and he can't practice medicine across state lines. So I don't know what kind of flack he's getting on the other end. I guess is considerable. So I didn't want to go back to John Hopkins right away because first of all, getting an appointment at John Hopkins is usually a 2-3 month ordeal, and then if I would go back to probably Denmead, and Denmead doesn't answer my questions on my chart at all, so he doesn't talk to me once I leave his office. That's the end of it. So I can't work with a doctor that way. Antonarakis was totally the opposite. Antonarakis not only answered me in a couple of days, he answered me sometimes in a couple hours, most of the time, 2, 3, 4 hours, he'd have an answer back to me on my chart. So that's the type of doctor I want in the future. So anyway, I called the Inova Shar Center in Fairfax, and Fair Oaks campus of the Inova Shar Center, they got a building on the Fair Oaks campus. It's only about 15, 20 minutes away from me, which is great. And so I saw a oncologist there by the name of Joshua Allen. He's only been 8 years in practice. He's young, but he seems to be on top of things. He's so young, as a matter of fact, it made me feel really old because he looked like he was 20 years old. But I'm sure he's in his 30s, but he sure looks like he's 22 years old, especially when you can't see all his face with the face mask. He really looked young. Anyway, So I said, well, you know, how about Orgovyx and darolutamide? And I didn't think he would bite on that, but that's what I wanted. And so he says, okay, I'll go for the Orgovyx, he said. But he says it's going to cost you $2,000 a month. I said, well, wait a minute. Maybe I can do better than that. So one of the guys in my prostate cancer support group said I could get it for $68 for with enough pills for 3 months, and that's what I did. Basically, I got it last Friday. So tomorrow morning, I'm going to.
Hold on. Was that you got the Orgovyx for
Yes.
$68 or the Nubeca for $68?
No, $68 on the Orgovyx. He wouldn't give me the Nubeca.
Well, what's
And
he giving you? What's he going to give you along with the Orgovyx?
nothing for the first month. Then we're going to darolutamide. I'm sorry, abiraterone.
Okay.
Like Anton Marcus suggested.
Okay.
So you basically
So
suggested.
let me just say, we know Josh Allen. Richard Craymond, who's on this call, has been working with him on this call today, has been working with him for some time. As you say, he's a young guy. I'm not sure how seasoned he is. If it were me personally, I think I'd want somebody else looking over his shoulder. I'll be honest with you, Joel. You know, I would say, you know, one alternative is to see. I don't want to sound like a broken record, but she's amenable. See if you can't get Dr. E to work with Josh Allen, because I think that she's going to call better shots than. I mean, I don't think Josh Allen is bad, but I just don't think he has that experience, and I don't know why, with a diagnosis like yours, he feels it's necessary to wait a month and see where you go.
Yeah.
I mean,
Yeah.
was Antanarakis going to wait a month when he gave you the abiraterone and the hormone therapy?
No, he just made that was a one statement in one sentence that he made, but he never gave me any details on it because he didn't want to be my doctor anymore.
Yeah, I mean, you know, again, I mean, I think, and I'll let Richard speak because he has the direct experience, and we'll come to you momentarily on this, Richard. But I know that Richard's been getting other opinions from MSI-H and from different places. Now he has this foamy gland with prostate cancer, so that certainly confounds the situation. But I mean, I don't think there's anything wrong with having him. But I think you need somebody to look over his shoulder, and that's what I would do if it were me.
Well, he suggested himself that I don't drop John Hopkins. He says you need to still maintain communications with them because they have a lot of stuff that we don't have here. The Shar Center, like clinical trials, is one of the things he mentioned.
Yeah, but you don't have a doc you can work with at Johns Hopkins. You need to have a senior quarterback who you can work with.
Right, exactly. And I don't know who that would be at this
point. Right. And if it isn't Antanarakis, who would it be? I mean, we can give you a few that we know. Some of these docs we know are pretty willing to work with other docs and work outside of the state. And, you know, you could go back to Antanarakis and say, look, Josh Allen's willing to take on my care, but I would like you to be my quarterback. How would you feel about that? If he was my so-called name doc and you and he talk together. And if he says, no, it's not for me, then you got to find somebody else, whether it's, you know, somebody like Dr. E or someone like Paul Korn, who Ken works with GU Medoncs in Phoenix, Shmulewitz. I mean, you know, some of these docs are willing to work beyond.
How come some docs have a problem working across state lines and others don't? I don't get that.
I think you have to ask the docs. We can't answer that. I mean, go ahead.
It depends on where they're licensed and and what the state laws are. I mean, obviously, Eleni doesn't seem to have a problem working across state lines. And it may be that Texas laws are less strict.
Okay.
But
Okay.
I mean,
So the point is, am I doing the right thing? That's my question, I guess. Am I using the right meds here? I mean, I don't think anybody's going to give me darolutamide up front
Why?
until they,
Why not?
well,
You're castrate sensitive and you're metastatic.
Do you want me to go?
You're castrate sensitive and you're metastatic. So maybe some docs would. I mean, talk to Mike Yancey. He's here on the call. That's what he got. That's what he got Elaney to give him, and he's sitting in Tulsa. And this is the reason why we're saying to you, stretch out, get the best docs. We know some of these docs will work with you guys. They want to, and there are others who don't. And it's, I know we push Elaney a lot, but we push her because she's really accommodating and she gets it, and she understands quality of life issues.
she's impressive also. I've heard a couple of her lectures and she's very impressive.
so maybe Joel, maybe it's time to do it.
Yeah. Well, tomorrow I'm going for a DEXA scan, so he knew about that, and he knew about. He asked for testosterone, and he was going to give me a blood test. I said, no, I already got it. I got two weeks ago. I got it, so he was impressed with that. But he is not, far leaning in the foxhole, like we say in the military. He is doing based on what he learned and what the acceptable practices are. He's not another Antanarachus, that's for sure.
Well, he hasn't been around. I mean, he started practice in 2017.
Yep.
I mean, he's been doing this for 5 years, Joel.
Yep.
That does not give him and I think most of it is probably going to be garden variety for him. And I don't know that that's he's up to the task.
Okay, so right now I'm getting Dr. E as the main where I should go next.
Well, I mean, that would be my suggestion, but I mean, we can come up with a few other names, but that would be my suggestion. I don't know. I'd like to hear from I'd like to hear on this topic from Mike Yancey, and I'd like to hear from Richard Craymond, because, both of them have skin in the game. Mike, go ahead. I see you put your microphone on. Hey, Mike, I just want to tell you, we're recruiting guys to go to Alaska with you on the motorbike. David Muslin put his hand up. Okay.
All right. Just to kind of correct something, with Dr. E, of course, I'm on abiraterone, and of course, working across state lines. I live in Oklahoma, and of course, she is the one that pointed me towards Pluvicto, which I get my second treatment on Thursday. So that's kind of the summary of where I'm at.
So where are you getting the Pluvicto?
I'm getting that over in Rogers, Arkansas. That happened to be the closest location to me.
She prescribed Nubeca for she did prescribe Nubeca for one of our guys. I forget who it was. I mean, I lose track. I thought it was you, Mike, but I know that one of them, I know who it was. It was for Julian. She switched Julian onto Nubeca.
So, Richard, tell us about your experience in Innova.
Okay, Josh Allen is the primary local. It turns out we live 2 miles from Fair Oaks Hospital. And then I've got Mark Markowski at Johns Hopkins, who really is, if you want to call it calling the shots. And he's the one that when I started out said, "Oh, go do the chemo at the same time the ADT, and let's get something going with the cancer I have." and it's been working so far. And now we're on the Elgard and Abbey. I'll do it something I don't kill the pronunciation on. And that was Markowski that basically pulled that. And I know he's now been doing some research with what is it, Epstein, and they're interested in that, and we're connecting through my chart. For some reason that he's getting doctor's reports. He's not getting my test results. That'll fix tomorrow. And it's worked well as far as I'm concerned. We do since PSAs and T-tests have the results have been good.
How satisfied are you with Richard Kramer? How satisfied are you with Dr. Allen, Richard? And if you had your time again, would you do it this way with Dr. Allen, or would you do it a different way?
No, I actually would do it with that because he is local, and then I do have Markowski as the
so the
I don't know if you want to call him the quarterback or whatever you want to call it. We call it consulting because I do go over there to Maryland to see him as well.
Right. So the issue is who's going to be the quarterback, and I think with Richard, it's It seems like it's Markowski, and
it basically is. He's the one that, and the two of them work very well together.
Right. So the question is, Joel, whether you could switch away from Denmead.
Yeah. Okay. So yeah, I could
to
ask
another Hopkins doc. Now there's another person. What about Channing Paller?
Yeah, you're talking about Sibley now, right? Sibley, John Hopkins.
And Sibley is going to be much closer for you.
Right. Well,
Markowski, by the way, also goes to Sibley.
He does. I didn't know that. Okay.
Yeah, he told me go there. Don't keep driving up to Baltimore.
Huh. That's interesting. Okay. So Joel, the question is there a way you can wiggle out and use another Hopkins doc?
Don't know, but I'd definitely would rather use another Hopkins doc than Denmead.
Or would you rather go to Eleni?
Well, I know as long as I only have to travel there once or twice, I'd be rather go to her because I know from what I've heard of her at the last APCC conference and the couple of lectures she gave, I was really impressed about her knowledge.
Okay, so why don't you start there? It seems to me that that's the place to start right away.
All right. All right.
Explain your situation, that you got to move, she will know Antonorakis. You can say Antonorakis is your doc, and he says he can't be anymore, and you need a new doc.
Yeah.
And I wouldn't even mention Denmead.
Right. Okay.
And that you do have a local younger GU Med-Onc in Virginia.
Yeah, the only reason I went to Josh Allen is because I know he could take me right away. I was impressed. I called for an appointment, and 3 days later, I was seeing him. So that would never happen to John Hopkins.
Right.
Well, there's a reason. There is a reason.
The doctor.
There is a reason for that.
Joel.
Right. It's like the empty restaurant.
Now, Richard and I think have some other things in common. Now, Richard, don't you have RB1 and P10 and TP53 gene defects?
No, I do not.
That's not you. I'm mixing you up with somebody else who's local to the area.
Matter of fact, last week you asked me about the different genome tests and the complete sequence. And that was done by Markowski wanted that.
Okay, all right.
So Joel, but the other part is I think Eleni is really good with genetics. I think
Okay.
she would be really on top of things with genetics and targeted therapies.
Yeah, that's what I liked about Antonorakis, but unfortunately, he's not available anymore.
Okay, so let us know what she says next week.
All right, we'll do.
Hey, Herb, I just need to jump in here. I was reading through Joel's posting in the chat box, and he says Denmead refused to prescribe denosumab because he's not CRPC. To me, that borders on malpractice.
It wasn't
Anybody?
Denmead, that was
No.
the other guy.
Oh,
Yeah, no, that's Josh Allen is saying. I asked him about the bone strengthening medicine, and he says, "I can't do that until you go to CRPC."
That's
I don't know
not
if that's
true.
not true at all. If
Okay,
you
well,
have bone mets, you are eligible for any bone strengthening agent,
Right,
including
absolutely.
Extiva denosumab.
Okay, glad you guys caught that.
Right, and I got even with stage 3, I got Zometa.
Yeah, and so that actually makes me wonder a little bit about Josh Allen.
Okay.
Now
that doesn't make sense with what we've talked about. Because he's
General, there's something else I want to ask you. Are you dual registered, or can you be dual registered?
I'm not following your question. What's dual registered mean?
Means that you can get meds from the VA as well as your private insurance. I'm
Yes,
assuming you're on TRICARE, right?
Yes, I am TRICARE for life, and I can. And the answer to that is yes. Joe Gallo could probably confirm that, but yes, the answer to that is yes. I can get
Okay,
meds from both places.
So you can probably get, I think Orgovix is now provided through the VA. Joe will know better than me. And if you're dual registered, you can probably get it for $11 a month. And the same will be true of the Nubeca and the abiraterone and all the rest of the stuff. So for those of you who are vets, this is where you can really benefit from being dual registered. The big problem with that is that it's hard to get it done immediately because you have to jump through the VA hoops, and you have to get, first of all, you have to get a primary care physician, then you have to get the urologist, and then you have to get the oncologist. But if you jump through all those hoops, if you need the drugs and you've got certainly somebody from a center of excellence prescribing those drugs, the chances are you can get the VA to give them to you for $11 a month. Mr. Gallo, Captain Gallo, excuse me.
Yeah. That's all right. I actually got mine through Medicare, so that's couldn't tell you about the VA, but we can check that out.
Right.
And the one thing that Fox Chase did for me is they hooked me up with this group, and I can't remember the name of them now, that picked up my copay. So it was like the Medicare paid, the big chunk like they say they do, but my copay would have still been like $800 a month. And this group from Florida picked up the tab.
So guys, I think we have to move along. We're really.
I have one more question for Rick, please. As I understood it, darolutamide is only approved for non-metastatic MCSBC and also approved for the triplet therapy, but I'm not in those either categories.
I thought it just got approved for metastatic hormone sensitive. Len, did it just get approved for metastatic hormone sensitive, or was that only with chemo?
It did, but it was in combination with docetaxel triple therapy, technically. Okay. So, the thing is, Joe, there are quite a few guys that we're aware of, myself included, Peter Kafka, I don't know, maybe Dennis, I'm not sure.
Julian.
David.
Yeah, David Muslin, who are hormone sensitive and are using darolutamide. So you just need a good doc who'll go to bat for you and somehow convince the insurance companies to pay for it, because it happens. It happens.
You've answered my question. The answer is I have to go to Dr. E and I'll get it.
Right.
Yeah.
Look, we can't say you'll get it. We can say you've got a
She-
much better chance of
He's
getting it.
good at getting this stuff.
Right.
Okay.
And one last thing, one last thing before, and then we've got to move on. Just a plug for the vets group next week. Our vets group is next Thursday night. And if you're a vet or you know anyone else who is a vet, please come along to that group, because this is where we'll talk about how you get dual registered and how you can get the drugs through the VA.
Guys, we got to move on. Jeff, Marchi, what's doing?
Hello there.
Got to go to Ken.
I actually, Rick answered one question. I just wanted to mention, they came just, they're working on a device. They've already tested it on mice and it works great. That can monitor cancer tumor growth in real time. They attach it to you and it can tell whether the medicine that you're taking is actually affecting your tumors directly. And this is something that is, well, still in testing, but it works for, there's another thing, there's soon to be purple tomatoes, which will last longer, but the big thing about them is that they are like blueberries and other purple foods. They have in them an ingredient that, for example, with mice live 30% longer eating those tomatoes than they ate normal tomatoes. So it's also, I guess, like broccoli.
There you go. I knew where we were going. Mice like purple tomatoes.
Right, right. And
well,
but they got to remember that's all they ate. And if you would only eat purple tomatoes, you might live a long time too, but you may not like it.
You know, it's like the broccoli thing. This may,
And
you know,
blueberries.
Super broccoli, there may be some real benefits, and it'll have the same benefits as blueberries. That was the whole point.
Okay.
But I thought I'd bring it. Rick had mentioned, my brother was asking about taking Casodex, and they only gave him, at UCSF, they only gave him 2 days of Casodex before his Lupron shot.
How about that?
Yeah, is that likely to cause any issues? Anybody know?
Who knows?
It's going to cause him issues if he's got
Dave,
metastasis.
take a
Yes.
Yeah.
It could, but who's to say?
Who's to say?
Hi.
Hello.
Not good practice.
Okay. I'll check in again tomorrow when I go for my second radiation treatment.
Yeah, he had his first radiation treatment today, and he's had no negative effects so far.
That's great.
Okay. Okay, Gene.
Thank you,
Good to see
guys.
you both.
SBRT.
Whoever gave you the 2 days, you tell them you should have gotten at least 10. Tell them, because they screwed up. They obviously forgot and they gave you too late.
Maybe.
We got to move on, Gene.
Yeah, we do. I mean, David's yawning, and so therefore, David, let's. You're.
Okay,
What's
so
up?
I checked in maybe 3 weeks ago, and I'm happy Al Latimer's on, about gynacomastia, which is enlarged breasts. So I spoke to my radiation oncologist at Northwestern here in Chicago, and he can do it. He's very familiar with it, and he was suggesting 5 hits of radiation, and up to a total of 20 gray. Just thought I'd try to get some feedback on that. And he also told me, as Dr. John said, it won't reduce the size that they are currently, but it will reduce any future growth. And I don't know how much more future growth I'm going to have, but if I can stop it and have the radiation and stop the sensitivity, I think I would do that. And just looking for some feedback.
Well, I had 3 shots, not 5. I don't remember. I'd have to look up, you know, what the yeah, how much radiation they gave me, but I had 3, and it was early on.
Yep.
So it was early on before you had any sense of it.
Yes.
Because you did a
It was
proactive, correct, Gene?
it was
It was Joe.
prophylactic.
Go ahead, Joe. I'm sorry.
Yeah, Peter Kafka had it done, but I think it was after he was already progressing.
Right, right. And I progressed a little bit, and it bothers me, but if I can stop it, I'll just hang with it and see how I feel. And then if it really disturbs me after that, I can do something surgically, but I thought I'd just start with that.
Mm-hmm.
Joe, did it work?
Okay.
It's, you know, it's going to be relatively benign.
Right. That's what he said. Okay.
Okay.
I was wondering if it worked for Joe.
Al, yes?
Yes. How embarrassing are they now? I mean, is it serious yet, or just kind of annoying? It's just kind of annoying, and I just don't like the way they look. And you know, I can just, as I'm moving, I can feel them, and I can just feel it on my chest, and it just you know, it upsets me, bothers me. Yeah, well, I told you that I went through all that for years before I finally decided to have surgery. And looking back, it was the best thing I ever did because it just the problem is just gone. You know, I mean, I can go to the beach now. I can wear my golf shirts, whatever. And I had 2-3 months of recovery, but I've been fine since then. Yeah, I'm almost to the point where I'm embarrassed to wear just a t-shirt. Well, that's where I was in spades. Right. Got it. Got it.
No, if that's the case, then I think it's bad news. It's got to be done.
Right. Right. So I'm going to do the radiation, and then we'll see where it goes from there. And I'll report back, and I need to get an appointment.
Okay.
Thank you. Thank you, gentlemen.
Okay. Ken, what's up?
I just want to say one thing to David. David, 5 treatments for this purpose does sound a lot. I mean, they may be using small fractions, but it sounds a lot. I've not heard of someone doing 5. I've heard of them doing 2 or 3 like Joe did. I mean, it could be it's the same amount of radiation. They're just putting them into smaller fractions, but 5 sounds a lot.
Yeah, well, that's why I asked him how much gray, you know, how much radiation it really is, and he said it was 20. And he can, and that's why he suggested doing 5, because he does a very, very small amount every time, and he just thinks it's much easier and much safer. I was concerned about the same thing, so I questioned him on it, and that was his response, Rick.
Joe, do you know how much you got?
No, I'd have to go try to look it up. That's not right at hand. I don't think it was anywhere close to 20 though.
Yeah, it sounds a lot, and 20 sounds a lot, but I don't know, just for this purpose. It just sounds. Is this somebody? Is this at Northwestern? Your guy at Northwestern?
Yes, yes, and he'd be flexible. I think he'd do whatever I wanted him to do.
Right, but you know, maybe I'd ask somebody somewhere else too. It just sounds a lot for the purpose that you need it for.
Okay.
So here I'm just looked at a website that is respectable, and it says doses for gynecomastia range from 12 gray in 2 fractions to 20 gray in 5 fractions, all of which are well tolerated with mild skin erythema being the main adverse effect. So 20 gray is within the accepted range.
Yeah, and that's exactly what he told me.
Right, it's at the limit, and so David, it's up to you, but I think that's kind of like the top limit. I think I've always heard a lesser amount, like you know, closer to the other end, but it's up to you.
David, who's your oncologist there, Northwestern? If you don't mind me asking.
I don't have an oncologist at Northwestern.
I mean, a radiation oncologist.
Well, Dean Sejdev.
Oh, that's who I got too. Yeah. Okay.
Yeah, I like him. He did a great job on my 2 mets on my ribs.
Yeah, he did 2 on my spine. He did a good job. Yeah.
Yep. Okay.
Okay.
Thanks,
Ken
boys.
Anderson, how are you?
Well, let me pull over. You know, I'm just driving back from home. Hold on one sec. I'll pull over and then we can chat.
Okay. Do you want me to come back to you?
Yeah, if you give me like 10 minutes, if you can, I'll be home then, and
Okay.
then we can
10
chat.
minutes.
Yeah.
You got it. Okay.
Okay, good.
Jack, tell us what's up.
First, I want to apologize for barging in the other day at the wrong time. I'm sorry I did that. I didn't know.
Well, you got an earful.
I did. So I just want to give you a brief review. I won't take much time. I had a couple of questions, but I wanted to give you a follow-up. I saw Dr. Shinohara in California. You were right. In and out in a few minutes. He found nothing significant in the prostatic fossa. I asked him if he could go high and look into the pelvic node area, and he said it doesn't go that far, so he had no idea what was going on up there, and then he disappeared. So you were right. Very quick, in and out. He gave me the information I needed to hear, nothing significantly fine. Dr. Carroll followed shortly thereafter, and he ignored my question about Steve B. For the second time, as if I never said it, and for whatever reason he doesn't want to talk about it, confidentiality, I understand, as a physician, that we don't talk about patients. Dr. Carroll basically said, let's watch the kinetics of the PSA and let's do nothing at this juncture. And he said, let's keep in touch. And he left the room. However, I asked him a few questions before I blocked the door. And I said, this avidity issue, I need to focus on that. Am I avid or not? Sloan Kettering believes that I'm maybe the 10% non-avid, why I've had 2 PSMA scans, neither of which lit up. And Carol believes it's my PSA was too low. Second one, 0.52 PSA. First one, essentially around 0.3. He says, let's keep doing PSMA follow-ups as needed. I said, what about a choline scan or an accident scan? He said he doesn't believe those are going to be diagnostically effective at this point, although Kwan seems to think that's the place to go. And as you said, he's a good salesman. So I don't know at this point. I think I'm going to listen to Dr. Carroll, and thank you for Dr. Mario Belusic. She's a gem all around in every way. I enjoyed his expertise, his bedside manner, his style. I think he's going to be a very comfortable person to work with, and he seems very bright and capable.
But
He said,
Jack, they're all telling you the same thing, right?
Yeah, I know you're going to tell me just cool it and relax and, meditate and get in the zone. I understand all of that. But I am still not comfortable because I have this bug in my head from Sloan Kettering, and he keeps hammering on me to get radiation and hormones. And this is the MO at Sloan Kettering from the get-go. They really believe if you can't see it, treat it anyway. They really go for the pelvic fossa and the pelvic bed and just go in there and zap it,
Jack,
whether you can see it or not.
Jack,
Okay?
let me tell you something. My wife worked at Sloan Kettering for 10 years.
Okay.
Okay? And here's what she says. She says,
Tell me.
cancer is a money-making business.
You're fucking right.
And so you got to put that in context.
I do. I've read the whole book on cancer politics. I've been in medicine. I practiced 40 years. I understand the whole gig, So, but still, he kept saying it over and over. Zelensky said the same thing, both of them. That's when my PSA was 0.1 detectable for very early. So those guys really believe financially or whatever drives them that I should do it and they can cure it that way. He keeps saying it. You let it go too far, it's never going to be cured. So they give that scare tactics.
Can't cure it. Jack, you cannot cure it. We don't have a cure if you're Gleason 4 or higher. We don't have a cure. Read my lips. No
Why
cure.
does he keep saying
Anybody
curative
who tells you there is a cure, you challenge them. We don't have it.
Curative intent, Rick. Curative intent is the word, quote unquote.
Okay. Curative intent, I agree, but you said a cure.
No, okay, I'm sorry. But he keeps saying that I could have curative intent. Don't let it go too far. Now it's gone to 0.67. God knows where it is today. So I just feel a little anxious about that. Maybe I've lost an opportunity to go ahead and prevent, this thing from progressing. That's all. And that's the anxiety level is only a function of that. Okay. I mean, I'm 83 years old. Thank God. I had a lot of gratitude and however many years I have left. So I'm not afraid of dying. I just don't want to suffer, if at all possible. And so I'm just trying to understand the PSMA and the doubling time. It's 14 months, by the way, according to Belusic. And I know that's considered high for some, and because some people have a low doubling time, and I understand it may move in that direction. But right now, I'm gonna do the best I can to relax and enjoy my life, and hope that I don't have to. This doubling time doesn't speed up too rapidly.
So,
By the way, I
I
have a very
have
high
two.
testosterone. I have a very high testosterone level because I have a pituitary microadenoma. So my follicle stimulating hormone is 22.8. My testosterone 750. So I don't know how much of that is a driving factor.
You're Iron Man.
So I want to talk to two quick people. I want input from two quick people. I want a quick input from two people. That's a better way to say it. I'd like to hear what David Muslin has to say since he brought you into this crew. And I'd like to hear what your peer psychiatrist in this group, Dr. John, has to say, because at least then it's a peer talking to a peer. So David Muslin, why don't you start? Why don't you pick on Dr. Jack first?
Well, Dr. Jack has heard me say it many times. If I wish, number one, I wish I was in his shoes. Number two, if I can get to 83, I'll be very grateful. But man, just enjoy your life every day. Don't fucking do the drugs. Don't wait till it gets a little bit higher. Look for the tumors. Just enjoy every day, Jack. Don't blur your life with the drugs. And I know it's all anxiety driven, I can tell. Meditate, relax, chill, enjoy Key Biscayne, and breathe. Just breathe. Go ahead, John, Dr. John.
Good advice.
Go on,
Well,
Dr.
Jeff,
John.
it seems like I can remember a very similar frame of mind very early on in my diagnosis. I tried to talk them into starting me on hormone treatment before they were willing, and I tried to talk them into because I thought any minute now I'm going to be metastatic, and then I'm going to be in trouble, so we have to hurry up. But what I think I understand now is that I was already metastatic all along. I had grade 5 Gleason tissue in me. I was already at that stage. And I think it sounds like you have this idea that something bad is around the corner and you better get on it, because once it comes around the corner, you'll never catch it again. But I don't think that's the behavior of the disease. I don't think there's something coming around the corner that hasn't already happened yet that you can catch on time and prevent it from happening if you're not really aggressive against it right now. And I think that the reason that people are telling you to chill out and don't worry about it is because they also think that some fatal event is not around the corner, just about to come and appear, and you better get at it before it does. They seem to think that if you recur, then you still have time to deal with it. So I think the behavior of the disease is that it's not all of a sudden come up and get you like an alligator jumping out of the water. That's just not how it's going to behave. From what I hear from what everybody else is saying. Does that sound right, Herb and Rick?
Sounds right to me. I mean, your doubling time is 14 months.
And it's not going to suddenly become a doubling time of 1 month, right? We don't see that, right?
I guess that's what scares me, because it seemed to rapidly, it's been flat for 5 years, and just within the past 6 months, it started to fly up. So even though it's very small in terms of numerically, it just seems like it was very flat. I was told by Scardino my doubling time was 36 months, but I didn't realize, that the doubling time keeps shrinking over time. I guess even though I'm a physician, I'm not a medical oncologist. So I'm listening to all you guys, and as I've learned more, I'm realizing that Scardino just didn't give me the whole picture before he retired. He didn't prepare me for it. If he would have told me it's 36
Do
now,
we see doubling times, long doubling times, suddenly and rapidly become short doubling times? Like we've seen people on active surveillance and in low and intermediate who recur, but do we see them go from doubling times of 2 years to doubling times of 2 months quickly?
Not quickly. I mean, it's going to be,
No.
as you take PSA measurements, you calculate doubling time. And yes, if it starts to decrease, you catch it by frequent PSA measurements, right? And then you can step on it.
Right.
In other words, there's time to step on it, right? There's time.
Well, if you can find it. And that's the other thing, the modern thinking is if you don't see it, don't treat it. And the old fashioned thinking at Sloan Kettering is treat it anyway.
So unfortunately, we're kind of running out of time tonight.
Okay. You're giving me enough. Thanks.
But please come, stay with us, Jack. We'll listen to this and figure it out.
I will, and I'm learning so much, and I'm very grateful. Thank you.
I mean, you could choose to just get more aggressive. Your docs might go along with it.
Oh, they're totally.
It's not like it's impossible.
They got me all set up. Belusic, he disagreed, and he said, let's put on the brakes. They were ready. They had the amount of grays, and they were all set up to do the pelvic radiation, the IMRT, and the prostatic bed, and the ADT for 6 months. I had the whole thing set up and ready to go before I spoke to you guys, and before Carol and Belusic both said, cool it.
Well, if it's the only thing that will give you peace of mind, you could do it. We just know it feels bad.
I think I'm more concerned about the suffering than I am about the actual end. So it's not as much death that frightens me. I know.
Okay.
Call David anytime, Jack. I'm around.
Thank you. Thank you, David.
Okay. So, Mark, let's go to you next. You're muted. Okay.
I was so tired. I don't know how you guys stay up so late. But I just wanted to say thank you again for having this group and recording the group, because I definitely been listening to the group with my earbuds on the boardwalk here in Rehoboth, and I'm trying to exercise to get back into it. But we don't have time to go into the whole thing. But the main thing that I really heard tonight, I had Dr. Anton Narakis for about, I guess, 8 years. Now, of course, he's moved, and I'm also seeing Dr. Denmead, and I too have the same issue that he's not returning my call. Dr. Anton Narakis advised me not to go off of Lupron ADT medication at all, since I had mutations and I had bone metastasis, and he was recommending not to do the come off of it, to do a holiday or intermittent therapy. And then when I met with Dr. Denmead, he advised me to do my CT scans and bone scans. I'm doing that once a year. I'm still having a lot of sacrum pain, especially in my S1 area. That's where one of my tumors lesion originally was, and I'm starting to have a lot more pain the last couple of months. So they had me do another MRI, So I had my follow-up with my local oncologist here. She's also recommending me not to come off of ADT medication at all, Dr. Anton, but now Dr. Demi is saying that I could do intermittent therapy. I did reach out to Rick, and Rick talked to me several weeks ago, had a great conversation with him. You know, I wish I had somebody as good as Dr. Anton Narakis at Johns Hopkins. I mean, I reached out, I emailed him twice on his portal. I've called the office twice, not got one return phone call yet. So it's been very frustrating. And I've been on the ADD medication for, it's been 8 years now. I was first diagnosed at 46, 47 is when I had the bone metastasis. So I've been doing the Lupron therapy now for 8 years. And the good news is my PSA level's been less than 0.1. So I'm grateful for that.
So what are the issues you think you're facing now?
Well, I'd like to come off of the Lupron just because of the fatigue. I just turned 57 and I'm exhausted. Like today, I just did not feel well at all. If I exert myself, I am totally wiped out. And it's been getting worse in the last, I've been trying to exercise and trying to walk. I mean, I used to do triathlons back when I used to be in really good shape at 47. I'm just not at that point, and it's just been very frustrating. And especially, I'm usually in bed by like 9:30 is the latest. This 10 o'clock. I mean, that's why I'm like
sorry
talking.
to keep you up.
That's all right. I thought, well, if you guys can do it, I can do it.
So there's a couple of things I'd like to say to you, and especially with people like Len on the line, and David, Muslin, that another option, I mean, we can talk about how you might get it, but another option for somebody like you would be to see if you feel any better on a monotherapy second-line anti-androgen and see what it does. So you stop getting the Lupron, but you keep either abiraterone or enzalutamide or darolutamide or apalutamide or one of the others. Right now, I think you're only getting Lupron, right? You're not on abiraterone or one of the others, right?
No, I'm just on Lupron. That's the only thing I'm doing right now.
So
I was on Zometa, but I couldn't tolerate Zometa.
Well, Zometa was for your bones.
Yes, I know that. Yeah, I couldn't handle it.
Well, and again, there, if you need Zometa, then you can. They should be talking to you if they think you need it. They should be trying you on Xgeva or Prolia or something like that. But that's another topic. I think that what I'd like to hear is from some of these guys who are on monotherapy, what their attitude is, and then maybe you could take a total vacation. But what concerns me about a total vacation is this sacrum pain. When you said you just had another MRI, is that right, Mark?
Yes, correct.
And did it show more cancer in your S1 than before?
No, but I guess I never really realized the sizes before, but I guess it looks like it was like 1.9 by 2.9 centimeters. And then one was 2.3 by 1.4, and the other one was 4 millimeters. So I think it's just, and I did slip and fall on black ice this past winter, and they think that I fractured my pelvis, but it's not showing any new bone metastasis, which I'm grateful for. They're just suspicious about one area, and they want to correlate it with the PSA.
Well, again, it's hard to correlate with the PSA when you're at less than 0.1.
Exactly.
So that when somebody said we want to correlate it with the PSA and you're on LHRH, it makes me question their credibility because they don't get it. Now, what I would say is we've got to find a more accommodating doc who's willing to work with you. Who wants to say something about monotherapy as an alternative? Lem, can I pick on you?
Sure. Well, it depends on the monotherapy. I would say that if you go off Lupron and you just go on darolutamide, I think you'll find that you'll be feeling a lot better, a lot less fatigue. Because darolutamide is just, in the clinical trials, the side effects were closely tracking the side effects for the placebo. So, and that was my experience. You can hear from David in a minute, and maybe he has the same experience. Now, on the other hand, if you go on monotherapy with apalutamide or enzalutamide, Xtandi, you'll probably still feel at least as fatigued as you do now on Lupron, because those drugs are, for most guys, very fatiguing. So it depends on which monotherapy you go on.
How about abiraterone then?
But Abby would not achieve the goal because it's the same thing. You don't have any testosterone.
Yeah, Abby is kind of like a super Lupron.
Yeah.
Okay.
Excuse me, gentlemen. Anyway, I'd like to jump in here. Anyway, I was on the Lupron Abby for 5 years. Exercise-wise, the thing I used was a bicycle, because the bicycle, you can start it and get going even though you're tired, and then coast a while, and then to pedal a while, and that fatigue aspect started to go away. And so that's how I survived on the 2 drugs for 5 years, feeling pretty good.
Yeah, unfortunately, I can't sit on a regular bike. I actually bought myself a recumbent bike, but I'm not even able to do that. I mean, I have a purple pillow, and I try, but my sacrum is just, I'm in too much pain for trying to even ride a bike.
And I take it that the pain they can't irradiate, is what they told you.
No, they haven't told me that yet. I mean, I did have radiation back in 2015, and I had, I think it was 20. I was supposed to have 45, but they cut it back to 25.
Yeah, and that was for what? For your sacrum?
Yeah, for the salvage radiation and the sacrum.
And the other thing, Herb, is it may not be cancer. It may be a fracture.
Mm-hmm.
David Muslin, what do you have to say about monotherapy?
So before I speak about monotherapy, I'm just, that you've been on Lupron for 8 years and that you haven't gone castrate resistant yet is pretty amazing. And what I learned from my doc, it's 3 years is the average before you go. So you may have to get off of it anyway. And one of the big things that I've learned here at AnCan is you want to play. You don't want to be on you don't want to be on Lupron all the time, because the cancer is smarter than the Lupron, so to speak. Right. But I was on Lupron and abiraterone for 2 years, got off of it in September of last year, went on monotherapy, and I'm totally fine. I feel probably 200% better. I'm more clear. Still get a little tired in the afternoon, but I think that's just from being my age and at the speed that I run at. But I'm fine. My testosterone is up, which really makes me feel good, and my PSA is non-detectable. So it's working for me well.
Thank you. Yeah, I mean the mutations were, I guess it's called TP53, and the other one is ATM.
So, TP53, ATM are pretty common. How many guys right now have TP53 or ATM or both? Show of hands. I'm sure there's more. Is Joel not with us? Yeah, Joel's with us.
No,
Joel's
I mean,
got his hand up.
more than 50% are normally TP53 mutations in prostate. It's the most frequent.
I think the issue is we got to get you to a doc who's going to work with you and not tell you this is what we're going to do, but be sensitive. I don't know. I mean, any suggestions? Anybody want to talk about that?
And nobody has any recommendations at Hopkins anymore. I mean,
Well, I don't know. I think we've been through it. We've seen some negative things with Denmead lately, but we're hearing positive things about Mark Murkowski. And what about Pat Channing Powler? She gets a good no?
I just don't know. I don't know, but you could have a conversation. But the biggest issue is going to be switching within Hopkins.
Right.
Never
Well, I don't
easy.
know. Is it a big, have anybody tried and not been successful?
Yes, we've known people who
Well,
can't.
but wait a minute. If you were
able to switch.
Antonorakis with your doc, you can choose whoever you want.
That would be true.
So I don't think it's an issue. I mean, I know that Denmead and
hold
Mike,
on. Have you seen? Hold on, Herb. Have you seen Denmead since Antonorakis left?
I have. I saw him. I've seen him once.
Then you got a problem.
I don't know. I don't know.
I do. You got to trust me, Herb. It's really hard. There are a few institutions where you can do it, but Hopkins, they don't like it. Memorial Sloan Kettering, they don't like it. UCSF, they don't like it, but I can get it done at UCSF from contacts. Some of them you can do it, but it's very, very hard to change docs within the same institution.
I mean, I was going to complain to somebody because I haven't gotten any response from them at all since this is like August, the whole month. August 15th is the first time, and I have it documented.
So I will, all right, I'm going to ask Mike whether that's really true.
Okay. I hope you're right and I'm wrong. I will say that.
Well, thanks you guys. I appreciate it.
I will use the patient portal tonight and find out if it's really true.
And then, in the meantime, we've got to find you somebody who's going to be flexible and work with you at Hopkins, or you're going to have to consider going further afield, like we talked to Joel about.
Well, we also think Catherine Marshall has been pretty. I mean, she was Antonorakis' protege.
Yep, that could be a good option.
So all right, let me do some research here to see, Mark, what I can do, what I can find out with my Hopkins connection.
I can tell you how to get in touch with Mark if you need to, Herb.
Right. Well, my brother has a house in Rehoboth.
Awesome.
Where's Dr. O?
Norm, you had something to say?
I just wanted to tell Mark, when I was 45, I flipped off a four-wheeler in the woods, going slow, landing on my tailbone. I was 6 months before I could sit down. I mean, I was only 45, and that's a really painful one. So might ease your mind a little bit.
Yeah, I was going to say, most important thing for Mark to do is drill down on this pain in your sacral area, find out if it's cancer or not. Do you have some kind of stenosis? The disc being under pressure? That'll take because if they find out that it's not cancer, you could probably go on a drug holiday.
Right.
I mean, theoretically, it could be biopsied.
Yeah, I've done that before. That's not pleasant.
But I don't know. I had it done twice. And I didn't know it happened. So.
What were the results, Mark?
Well, that's when they found out. Originally, I had my biopsy back in 2015, and I mean that was going through the SI joint to get into the S1, and I mean that's where the pain's coming from, and that's why I kept on thinking that's it might not be the cancer, but it's definitely hurting. I mean it's back up to 6, 7, 8.
No, you need something. You need to get this looked at, but really carefully. You can't. If that pain is that intense, Mark, you got to figure out what to do.
Yeah, I'm seeing my local oncologist on this Friday. I'm getting my blood work done on Wednesday, and I see her, my local oncologist, and I'm hoping that, and she had a good relationship with Dr. Anton. They talked, they communicated, they went back and forth. It was awesome. But
So
this
the
guy,
other question I had, and maybe Len, you could help me with this. All right, his PSA is really low, right? But there's a big spot somewhere on an imaging, right? Is it really unlikely that if it were that cancer, it wouldn't be picked up with a PSMA PET despite low PSA?
Well, of course, it's always possible that his cancer cells are not producing PSMA.
Right.
and that's what Dr. Anton exactly what he said. He said, for some reason, my might not show up in the PSA.
So what about a liquid biopsy, an FMI liquid biopsy? That would pick up circulating tumor cells, and it would tell you if they're PSA positive. It would give you some information and about tumor burden. So if you're PSA negative but producing tumors, a liquid biopsy should find them.
Okay.
Well, also an Axumin PET scan or a choline PET scan or even an FDG PET scan will monitor the metabolism of that tumor and will show activity if it is cancer, high activity.
It's true.
Yeah, but you don't.
But we need a quarterback
we
who's
know
going to do.
you don't get a result. You don't get a result at 0.1, and the problem is he's at 0.1. Yes, it would. But do you get a result when you're at 0.1? Now, the issue that's being asked is something different. What's being asked is, what if there's a large spot there that's doing something, but we're suppressing the PSA through the LHRH? Will it still show up? And I don't think it will. But I'm not a doc. That's just my own gut feeling. But I don't know. I tend to doubt it will show up if you're suppressing the PSA, whether it's from PSMA, Axumin, anything
But
else.
wouldn't it
I
make
don't
sense
know.
to get some sort of scan just to see if it's something else, like it's a spinal issue, or, at least you would know maybe another cause for it?
Well,
MRI would
the
show if
answer
the
is
nerves
yes.
are being squished.
I mean, Mark, if a guy came in, if a patient came into you with your complaint, what sort of scanning would you suggest they talk to their doc about?
I mean, I thought the MRI would show something, or the CT scan, but not the bone scan doesn't show anything new. That just shows the treated, bone metastasis, and it's just showing that now with severe pain in the right sacrum and the buttocks. Well, I don't have pain in the buttocks, but definitely in the right sacrum.
Would an MRI show anything?
It just shows, it says please coordinate with the PSA, but it shows 4 different impressions, and mild edema in the right iliac bone lesion, likely representing the osteoporosis stress response pending insufficiency fracture as opposed to an active metastasis. Given the long-term size stability, please correlate with a PSA. No abdominal or abnormal soft tissue findings.
We can't correlate with the PSA. That's why we're having this discussion. But I think we got to move on, Mark. But I think we've given a few things to think about. I think that we definitely need to switch you to a better GU Med-Onc, and frankly, if we can do that at Hopkins, and if you don't like him, then we'll talk again about somebody else. But I do think that monotherapy, especially if we can do monotherapy, darolutamide might be a good option for you.
Well, thank you guys. I really appreciate it. You guys have a good
Okay.
night.
Okay. We will try to finish up. Well, I'm going to stay as long as necessary, but if people have to go, okay. Ken Anderson, thank you for waiting.
No, it's not okay. No, it's quite late, so I'm going to try to keep it short. Let's see, where do I start? I've had 3 cycles of lutetium. It doesn't appear to be working for me. You know, Paul, unfortunately, at MD Anderson's on vacation till the 23rd. So I kind of made a judgment call and went ahead and said yes to the 4th round of lutetium. My PSA has gone up, 70 points in 5 months. And I don't know if I just had another PMSA PET scan. I don't have the results from it. I'm more than willing to go in and zap a few mets if I can find some bad apples. Most likely, Paul's going to have me switch it out and start cabazitaxel, but I'm not sure yet. I'm just going to do the 4th round of lutetium and see what happens. I'm not anticipating anything remarkable. It doesn't seem to be a treatment option for me. So, although my PSA is not doubling fast, I don't have any bone pain, I don't have any pain per se. So even though my PSA right now is at 177, I mean, I'm still up running around. I always say I'm still vertical. So, that's about it.
Wow. So it's just been steadily going up even with lutetium.
Yeah, it's been going up about 25 points every 3 months. No, a little less than that because in 5 months it's gone up 77 points. So I would say lutetium is working to a degree on some. I mean, originally Paul said I was PSMA avid. I mean, he was pretty shocked when it wasn't working as well as he thought it would. So don't know. His comment probably would have been to switch me to cabazitaxel sooner, but he wasn't available. I couldn't really ask him.
I mean, the other issue would be, what about a bite?
Bispecific T-cell engager, I don't think that's a bad idea. But I have to
I
run it by
mean,
Paul.
if you're PSMA avid, it may be that just lutetium is the problem rather than the targeting, whereas a bite is a different mechanism.
That's a good idea.
Mm-hmm.
So, I mean, we saw very positive results coming out of the trials, especially from Regeneron.
I don't think it's off the table. I mean, I'm more than willing to do a clinical trial between, lutetium and cabazitaxel. Just got to pick one. I have Mass Bio and Cancer Cure Commons or whatever it's called. They're both generating based on my history outlines of what clinical trials they think might be most effective for me. And I do have the one from Cancer Commons back. What's at the top of the list? I don't have it off the top of my head. Probably is a bite, Herb.
Yeah.
Mass Bio just recently got my PET scan because I had a PSMA PET scan done on Thursday, and I don't have the results back yet. I'm going to talk to Dr. Wong on Tuesday. I've already sent the disc on to Paul for his review when he gets back on the 23rd. So there's no doubt there's some cancer floating around that's active. I don't know where it is at the moment. The PET scan should tell me.
Right.
Did Paul order a second type of scan that's not PSMA dependent, just to see if there are any non-PSMA active lesions?
At the moment, I'd asked for an axon scan to do a comparison, and Dr. Wong said it wasn't necessary, but I haven't talked to Paul because he's been on vacation since the 1st of the month. He was supposed to be back. I don't know. I hope he's not leaving. I know MD Anderson's, I don't know what he's doing. So He said he's coming back on the 23rd. First it was the 21st, now it's the 23rd. So we'll see. It's not freaking me out though. You know, I must say the guys on here that are worried about, you know, a point here, a point there. I was there at one time, don't get me wrong. But you know, I'm not gonna let it freak me out. Yeah, we'll see what happens. Cabazitaxel will probably work for a while, probably not very long.
Well,
but
it'll get you to something else.
What's that?
It'll be a bridge.
Yeah, I'd rather do a bite trial in between lutetium. I also might go to Australia and do actinium 2 cycles. So there's some evidence, but I want to chat with Paul about that first. You know, that Genesis Care, Nate Lenzo said, you know, I chatted with him, and he said it's quite possible that it might do something. No guarantees though. And I know I can handle it. I know Bryce Olson didn't have a very good time on actinium, but I don't think I don't know. I think I can handle it. I don't know.
I mean, I take it that all your blood numbers, all your hematology numbers are good, even after 3 cycles.
Yeah, they're not. It's not crazy. In fact, the funny thing is, in the past, my alkaline phosphatase and PSA were running pretty parallel on the graph, and now they've separated. PSA is going up, but alk phosphatate's still at like 60, 58, 61. So
that's
maybe
interesting.
That is interesting, I think. You know, it tells me potentially that it's moved from bone to something else, and maybe there's something else that I can go after and get a biopsy on. So don't know yet.
All right, Ken, let's hear next week. I hope you get the results.
Well, next week I'll be in Wyoming, and I don't know how the internet service will be, so I can't I'll be on chat because I'll be fly fishing.
Well, just send us an email.
All right, Herb, will do. Thanks for hanging out.
Anyhow, I do want to we have one more person before we all fall asleep. So, John Madden.
Hi, I'll try to be as quick as I can. I've been to see 4 quarterbacks now, 2 here in Houston, MD Anderson and Baylor College of Medicine, and then I went and saw Quan at Mayo and Small out at UCSF. So I've had some really good input, but Quan and the local Baylor College of Medicine doctor are recommending the triplet approach for my situation.
Hold on a second, John. Have you ever been with us before? Because I don't have any notes on you.
No,
are you new?
Oh, you're new. So look,
yeah.
John. So where I missed that, and you were late, I think, or I missed it. But can we put you first next week?
Okay.
Oh, no. Yeah. We'll be meeting next Tuesday night at 6 p.m. Eastern. So I'm sorry I missed that. But if you would be, we can talk about, unless it's urgent, we can talk about it next week.
Well, I kind of have to make the call on which route to go, and if I'm going to.
Then are people willing
when
to stay?
do you have to do that? When do you have to do that, John?
Well, I'm on schedule to start the pre-scans for the chemo on the 27th, and to get.
So let me just see. Our next meeting is the 27th. So, you know, guys, if you're willing to stick around, we'll just do an intake because we can't do it. We can't do it on this basis. We've got to do an intake. So
hold on a minute, John. You said you're getting the scans on the 27th.
Yes,
but no therapy yet.
Yeah, they've held off because I crashed my bicycle and broke some bones, and they were waiting for that to heal.
So if you're not getting any therapy, I think we might have some time, right, Rick?
Well, I'm sorry, I'm on Lupron. I've been through a month of Firmagon and about a month into Lupron. PSA's coming down pretty well, responding. I'm supposed to be on Zytiga, but
Here's our problem, John. I think you were in fairly early. We need to do an intake because we can't, without knowing your history and where you're at, we can't navigate you. And we're happy to do it, but we're 35 minutes over time. If you really need to do it before next Tuesday, you can be the judge. If you're really willing to want to do it before next Tuesday, I'm willing to stay on and just talk to you myself. If you feel you can wait until next Tuesday, we meet at 5 o'clock next Tuesday. Len will be in the chair. We can take you as the first person, but we screwed up. We're sorry, but I don't want to disappoint you tonight. So if you want to go through it tonight, we'll go through the questions, and whoever stays on will give you their input back. Some of the guys are going to stay on.
Well, just out of respect, I guess I'll just wait till next Tuesday. Thanks a lot for putting this on. It's really informative and you know, good luck to everybody with your problems. I wish I knew nothing about this.
We all do.
Everybody does. So Len, you'll remember that the first person up next week is John Madden, right?
Yes, sir.
And then also Al Latimer also asked to be put off till next week.
And John, if something urgent comes up between now and next Tuesday, you can email us. I'll give you my email, and if any of the other guys want to volunteer their emails,
you can email me for sure.
Okay, so email Herb, Herb,
at AnCan.org.
at AnCan.org. So reach out to Herb if it's urgent, and if not, we'll talk to you next Tuesday. We'll give you plenty of time.
Or basically, even if you want to have a short phone call tomorrow or the next day, I'm willing to chat just to see if really it is urgent or it's something we can talk about next Tuesday.
What time is it next Tuesday, 5 or 6? You mentioned 2 times.
I said, well, it's 6 o'clock Eastern, but he's in Houston.
Okay.
For you, Jack, it's 6.
Right. So again, everybody, because I know there's confusion. People come in late. Monday meetings are at 8 o'clock Eastern. Tuesday meetings are at 6 o'clock Eastern. That never changes. Okay. So that's always the case. And John, John Madden, you're muted right now, but is that okay? Will that work for you? That you can reach out to Herb, talk to Herb, and then we'll get you up next week if there's something, if there's something urgent, we can back you up.
Yeah, that works well. I missed last week because I was in San Francisco, and then the first week I missed because I didn't know there was Monday and Tuesday. So
okay,
understood. Thank you.
Okay.
Thank you.
I thank everybody for staying, and I will stop the recording. And then